senior surgeon, Nashik, very dear friend, organizes a fantastic meeting there. I think it's called the Maharashtra Oncology Conference. Let us start with the video. So this is a 54-year-old lady, postmenopausal, presented with a 3 by 2 centimeter lump in the right breast with no positive history of malignancy. The performance status is good. So this is the size of the lump. It's located at 11 o'clock position, free from the skin and the muscle. There is a single axillary node palpable. The contralateral breast is normal. The systemic examination is normal. Mammogram shows a 2.5 by 2 centimeter BIRADS 4 lesion. Right breast, 11 o'clock position, axillary node, which is 12 by 7 millimeter in size. A core biopsy has been done. For the benefit of the postgraduates, FNAC is not to be done. We do always a handheld core needle biopsy or an ultrasound guided core needle biopsy. Diagnosis and immunohistochemistry. She turned out to be ER/PR positive, HER2 negative, with a Ki67 of about 30%, and her metastatic workup is normal, and she was planned for a breast conserving surgery. Is being marked. It's at 11 o'clock position, 3 by 2 centimeters in size. Because the tumor is close to the nipple-areolar complex, we put the incision right periareolar. As far as possible, we try and keep the incisions as cosmetically so inframammary fold, periareolar incisions are preferred. The incision is being deepened there with the help of the diathermy. So depending upon the size of the lump and the location of the lump, you can choose your incision. The flap is being raised. Make sure that the thickness, depending upon the location of the tumor, we don't have a mammogram in this particular case to tell you where exactly the lump is, but keep the flaps thick. The lump has been identified, and I use a finger, the finger being approximately 1 centimeter thick, to get a good gross margin, and it would be a good idea. But the other way of doing it is keep the tumor inside at all times and incise right down to the pectoral fascia, depending upon again the location of the tumor. In all cases, it may not be necessary to go right down to the pectoral fascia. If the tumor is superficial and you are able to obtain a 1 centimeter margin, you may not go down to the pectoral fascia, which is of course recommended. Once the tumor has come out, the specimen has to be oriented. This is a very important step. Short stitch superior, a long stitch lateral, and clips are placed at the margins and base of resection. This helps in giving post-operative radiotherapy boost to the local part. Meanwhile, Dr. Nagarkar has started doing the axillary dissection because a single lymph node was positive. So you already seen the axillary dissection being done by Dr. Naresh Soni. The steps remain the same. The incision is deepened. You identify the lateral border of the pectoralis major. You identify the lateral border of the pectoralis minor. You identify the pectoral pedicles. Make sure not to damage it so that the muscle doesn't atrophy. Incise the clavipectoral fascia. All the fibrofatty tissue has to be removed. Any small lymphatic, even presumed lymphatics, please clip it with a metallic clip. Bigger clips, make sure to either tie them, vessels, clip them, tie them. Identify the long thoracic nerve, nerve to serratus anterior, the most important step. Otherwise, it can lead to a winging scapula. That is the nerve to serratus anterior you just saw. Dr. Nagarkar is tying some superficial veins coming out from the axillary vein. They can bleed and make your operative field messy. Make sure to tie them, clip them, not cauterize them. The next step is to identify the thoracodorsal pedicle. So all the interneural tissue between the serratus anterior and the thoracodorsal pedicle is now being dissected. I think with a single node positive, a level 1-2 lymph node dissection should be good enough for her. We do not do a level 3 very aggressive, no dissection if the gross lymphadenopathy is not there at level 1, 2. Dr. Nagarkar is a very senior, skilled surgeon, and he is proceeding much faster than I can speak. So I need to catch my breath in between. That is the latissimus dorsi muscle coming into view, and the specimen is being gradually delivered from medial. So that is the thoracodorsal pedicle. On the chest wall, you can see the long thoracic nerve. All the fibro tissue has to be removed. At the end of it, give a clean wash, put a drain, palpate if there are any nodes. The another trick of axillary dissection is make sure that you do not go above the axillary vein, remain below, and clip as many vessels coming out from, and that's an excellent cosmetic closure of the same patient. I think you can close the video and open the house for discussion. I'm sure any of the postgraduates can want to ask any questions regarding breast conserving surgery. I or any of the panelists sitting at this table or that will be happy to answer them.
Any question from the audience?
Kalyan.
The margin, what is that margin require? Negative margin.
So the gross margin is about 1 centimeter away from the tumor. So then you keep palpating the tumor at all times and incise in around all times. There are two ways that we can achieve good margin. One, when you have raised the flap, you can mark with the ink the tumor or the area that you want to excise with your marker pen, and then excise the tumor accordingly. I do like a ellipse. So the ellipse is the shape that can close very elegantly like this. You know, it's like a door hinge. Dr. Som Shekhar, who was to come here, our past president ABSI, he also has a lot of experience in doing sentinel lymph node biopsy and one of the pioneers actually in doing this ICG based dye, a very big experience. So he does what is called as bread crumb. So then he cuts like a bread crumb. So tumor is in the center, 4 sides, 1, 2, 3, 4 like this. But then I think that is a little more difficult to close. So, but then there are various ways. Gross margin 1 centimeter and microscopic margin is no ink at margin is good enough to get clear margins.
Classical breast conservation surgery that we see, just taking out the lump and leaving the cavity, is now reserved for very, very small lumps in possibly large breasts. I think in most instances now the volume of breast that we tend to take out will demand some of the other level of oncoplasty to be performed. So most of us, I think, would be doing more oncoplasties than we are doing traditional breast conservation surgeries. And that is important because cosmetically you will get some kind of a saucering or a dimpling at these spots if you do just lumpectomy and leave it as such.
Another point that I would like to make is that we do not leave behind a cavity at any point of time. So I don't know whether the video ran too fast. So whatever are the two cut edges, we try and oppose them. If it is a fatty breast, then you take as few sutures as possible because there is likely to be a lot of fat necrosis and oil cysts. If it is a fibrous breast, then you can take sutures at the pectoral, the fascia level, mid level. If it is fatty breast, avoid taking so many, but close the cavity is an important message that this video also wants to send. Yes, Dr.
Another important point is your anterior margin should be always discussed with the pathologist, because many times they say your anterior margin is very close. When somebody else reports that, and if it goes for a second opinion, they say that margin is positive, requires the surgery. So whenever you are marking a flap, many times, as it done in Milan Institute, and I do it routinely, excision of the elliptical skin in that area, so that margin becomes negative. Then whatever you are mentioning, closure and everything becomes more easy. This is one point most of the people has to remember, commenting on the anterior margin by the pathologist, which confuses most of the time, especially the patient's community, because we know that we are away from that. but it gives a wrong impression in when they are reviewing the second opinions and other things. So your best thing is you can take out the ellipse of skin and then subject it when because negativity means a lot of good prognostic factors in planning of the treatment.
If the tumor is close to the skin, then we generally tend to remove the overlying skin. If the tumor appears to be on mammogram clinical examination away from the skin, then there is a likelihood that we may not excise the skin. Marking the base of the tumor is very important, because opposite to the base is the anterior, the posterior margin is the base, and opposite to that is the anterior margin. So that is one way you can orient, but I entirely agree with you that we have to be very careful about the anterior margin. Yes, doctor.
Yeah, I think regarding the margin palpation guided resection, it is a surgical skill every trainee has to master it. So you are not seeing the tumor, but before that you need to have a good look at the clinical assessment and the mammography. You should know the plane of tumor, shape of the tumor. It need not be square or round. You need to tailor it according to the tumor shape. So that has to be there in your mind when you are coming to the table. Then you need to train your fingers, how the tumor feels through the normal parenchyma. That's why I always tell my trainees when they do MRM, try to feel the tumor, how it feels. You train your finger, then you can master the good margin negative resections. A lot of surgical skill and visualization is involved. So in the beginning, it's better to go for more than 1 centimeter. If you are starting your BCT programs, a slightly over margin is absolutely fine. But as you learn your skills, with the cases, you can master the technique. So palpation guided BCS is a lot depends on the skill and training of the individual.
I think we are so much worried
Dr.
about
Dr. Tarang, last comment. Yes, sir.
Small comment. When you do a round block, you need to dissect far beyond the tumor margin when you raise the flap. Otherwise, you won't be able to close nicely and there will be crumpling. Second thing is, margin is against the cosmesis result. So much more larger margin doesn't serve anything but spoils your cosmesis. So individual institute has their own protocol, like you have a 10 millimeter margin, I have a 5 millimeter margin in my study. So my pathologist always call me, it's just a 4 millimeter margin, you go ahead and do more. If there is 7 or 8 millimeter margin, I am happy with it. Thank you.
But on the table, it is very difficult to measure the margin.
Difficult.
So that is why, because you get it after the surgery most of the time.
The most important is the type of the breast we deal with, whether it's a mature breast, immature breast, pendulous breast. Then only you have to mark the incision, give a good margin. That's one of the important things. Many times we forget to address the type of the breast we are dealing with. The one technique doesn't fit all, basically. Some of the things are not good for round block techniques, especially when the tumor is situated in the lateral wall. You have to adopt the different technique for BCS. So we have to classify the breast and then choose the type of surgery we perform on these patients.
Thank you for the comments, and shall we? Is there any other question?
Yeah. So it is very important to have good and adequate negative margins, but then we have to make sure that every centimeter increase in gross margin will lead to the volume of excision being raised to the power of 3. So if we excise the tissue, like a sphere or even a cylinder, then the volume is 4 by 3 pi r cube. So if you excise like a 3 centimeter all around, then it would be 27 centimeter cube. If you excise like 5 centimeter all around, the volume of excision will go as high as 125.
Yes.
So that may have an impact on the later cosmesis. So yes, it is imperative to have a good adequate negative margin, but in an over enthusiasm, we should not be more radical towards achieving like
Thank you,
more radical margins.
Tanay, for the comment. Yes, sir.
Technique. We are happy to have very senior office bearers, the president and one of the past presidents of the ABSI with us, Dr. Dev and Dr. Diptendra. The next ABSI conference is to be held in Ahmedabad. So this is a sort of a curtain raiser for the same, and we will certainly interact with Dr. Tarang Patel, Dr. Jayesh Patel, and all the organizing committees, and have a regional state-wise committee, and look forward to support from Dr. Rajiv Bhatt from Baroda, and my friend Dr. Nitin Tolia at Rajkot. They are all very senior surgeons and they are key opinion leaders in their own area. So they will be given specific responsibilities in making sure that ABSICON 2023 is a success. It's not one man, as we saw in Hyderabad recently, doesn't make a conference. It takes multiple people to make sure that this thing is a success. So the round block technique is an elegant oncoplastic technique. So again, this is a 52-year-old lady. We seem to have a lot of 52-year-old ladies today, 2 centimeters in size at 5 o'clock position. As you can see, the tumor is located exactly at the center between the skin and the pectoral fascia. And here we are using a blue dye, a methylene blue injected subcutaneous subdermal, and the massage is given so that the dye reaches the sentinel lymph node. Here, usually we do the sentinel lymph node first. If you do the sentinel lymph node biopsy after the mastectomy, after the breast surgery, it is likely that you will get, the dye will get diluted and you might end up removing more nodes. But for the sake of the video, we have done. So, the tram track incisions have already been placed, 2 parallel incisions, one at the periareolar region, one about 5 millimeter, 7 millimeter beyond that, and they have already been placed with the 15 number blade, and they have already been de-epithelialized. I will not go, you are all very experienced surgeons, not waste your time in showing you how it is to be de-epithelialized. That is how the de-epithelialized area looks like. And that is the dermis on one side and that is the dermis on the other side, which we will suture so that the, the circle doesn't widen. So that is the flap thickness that we are looking at. The flaps are being raised. The tumor is being palpated. The tumor has been marked with the blue dye, as I told you. So now we will excise just beyond that with a 1 centimeter margin. So one side has already been incised. We have gone deep enough. We keep palpating the tumor at all times. Superior dissection is being carried out now. And now only the lateral side is left. The tumor has already been, you can go beyond the tumor, palpate it and keep it in the center. We tend to take the stitches before the specimen comes out because sometimes it can roll over and you don't know which side is anterior. Maintaining good hemostasis at all times. So that is how the cavity will look like. The tumor is now being delivered out of the wound. Short stitch superior, long stitch lateral, and ink at the base of resection because we have not removed the overlying skin. That is how the cavity will look like. Short stitch clips also have been placed at the margins. We do a specimen mammogram. I think it is a very effective way. The tumor is exactly in the center. You can also see some microcalcification within. No microcalcification or the tumor extending to the margins as seen on the specimen mammogram. Very simple, cost-effective way of margin assessment. Now we proceed with the sentinel node. You have seen more elegant videos of the ICG based sentinel lymph node biopsy on this, but this is a blue dye based. The only limitation I see of using a methylene blue is that there is no guidance. So it's like for hunting, and sometimes it becomes like hunting for a needle in a haystack and in a big fatty breast. Here, when you do ICG, which Dr. Rajiv Bhatt does, it is more guided. He knows exactly where to put the incision, where is the lymph node. So that guidance is important, but I think we have been practicing for so long. So most of us are fairly comfortable with methylene blue based sentinel biopsy. That is The lymph node, as you can see, the blue has gone there, so that is acting as a guide to where the lymph node is likely to be. You can see the intercostobrachial nerve crossing the wound. There is the blue dye. I think it's a good practice not to remove, like again Rajiv said, to remove too much of axillary tissue, restrict it to 2 or 3. Your average, your median number should not be more than 2, I think. Removing 4, 5, 6, 7 nodes doesn't help the purpose, and the chances of lymphedema are the same as it would be with almost like an ALND. So another trick, I think Dr. Rajiv also alluded to it, is to keep a bit of soft tissue around the lymph node. Don't remove bare the lymph node, because there could be some extra nodal spread if the node is involved. So whenever you remove the node so that it doesn't spill, you can remove with a little fibrofatty tissue around the blue node or the green node or the hot node, as the case may be. No one technique is superior to the other. Whatever you are comfortable with, wherever our young friends go and practice, first do your own pilot study, establish your false positive, false negative rates, and if they are within acceptable rates of 5 to 10%, then you can initiate a sentinel lymph node biopsy program. The two pillars are in view. As I told you, we excise it like an ellipse, and interrupted sutures with Vicryl. Clips have been placed at the margins of resection, and interrupted Vicryl sutures have been placed, and they will be knotted over soon. Good fibrous tissue all around, so I think the stitches should hold. And there the two pillars are coming into view, and we will just make sure to show you that there is no tension on the sutures. And they are tied sequentially. The video has been prepared by my colleague Dr. Bhavesh Patel, who has been my partner for the last 10 to 12 years. The last suture also has been tied. The two good fibrous tissue is coming into view. The stitches are holding well, no cut through. The cavity is being obliterated. So now we are taking interrupted dermal stitches so that the scar doesn't widen. You can either take them with proline as well, but proline sometimes post radiation sticks out like, it comes out of the wound. Then we do a subcuticular closure of the wound, bringing the epidermis and the dermis into close approximation. That is how it would look like at the end of the surgery. And the scar in the axilla. This is her post-operative result. Post-radiation, there is some edema over the breast, some pigmentation as well. Some other post-operative results in which we have done from our library, where we have done round block technique. Here the scar has widened and the scar goes outside the areola and appears quite not so cosmetically acceptable.
Thank you, sir. Thank you, sir. It was an excellent video for the right block technique, and it's not only for the periareolar tissue. Modified round block works for the all quadrants. There was a paper which fits for the all the quadrants. Do you use a non-absorbable suture material or absorbable suture material? Because it requires a 3-layer of closure of when you do this technique.
We use an absorbable suture material, hoping that it will stay as long and give good wound strength. But some people use proline,
Non-absorbable suture material.
non-absorbable sutures as well.
Because I think muscle to gland and glandular and dermodermal sutures are also required. Any questions or comment from audience? And
Use the mic. The mic is here.
Sir, is there any difference in the injection of methylene blue whether periareolar or peritumoral for a tumor located in the inner quadrant regarding identification of lymph node in the axilla? Is there any difference in the inner quadrant tumor whether to inject dye peritumorally or periareolarly?
There is no difference depending upon the location of the tumor and the site of injection and the level of injection. So whatever works best in your hands is the best technique. So it doesn't matter depending upon the location of the tumor. I think the experts can also have a word on that, that if the tumor is located in the inner quadrant and you do a radioactive dye, then sometimes you might pick up an internal mammary node as well. So that has happened, but not a lot of experience with using radioactive dye. So, Dr. Dev, Dr. Diptendra, anything that you would want to say on the site of injection and the location
the site
of the tumor?
actually does not matter because now we are going with the anatomical concept of injections. But medial quadrant location tumors, they have a high predilection for internal mammary, which can be picked up with gamma probes, radioisotope guided. But anyway, it is not going to change your management because as per current standard of care, we are not going to dissect any internal mammary nodes.
Yes. Thank
So
you,
it is
sir.
not going to make any difference.
any other question? Any comment from the seniors? Are there?
Very important technique which Vijay has done and shown here is that before approximating the pillars, you take a few sutures around the nipple and the areola complex, to sort of anchor that and then put the pillars together. That's very important. You start putting the pillars together. Before you do that, you will have problems in the central area.
Sonography guided. So, Dr. Dev works in the same institute where there are surgeons who do ultrasound guided this thing. But I think there is no advantage, not an advantage, I would say, no study which says that doing an ultrasound guided excision is superior to doing it with, palpating the tumor at all times. Different ways, I think Dr. Gajjar asked about margin or Dr. Jayesh Pai asked. So, in the foreign countries, they have a re-exploration rate of 20%. So somehow in our hands, the margin revision is less than 10%. So they have margin probe, margin cavity shavings, lot of ways in which you can bring down the rate of a positive margin, which is, the most important step in breast conservation surgery. So it is a matter of experience, skill, and most important, whatever works best in your hands, keep doing. If it is not broken, don't mend it. If it is working good in your hands, if Rajiv Bhatt is doing a damn good blue, methylene blue, let him continue to do. He's been doing it for now 28 years, and he will continue to do it hopefully for the next decade or so.
I just want to comment about the
Last question.
ultrasonography
The
guided
important question
margin
is
decision.
when you will convert in a mastectomy, what are the indications for going for mastectomy if conservative breast surgery?
I think repeated margin positivity is an indication. Now, having said that, how many margins positive? Two should be considered as a, that would draw the line. So beyond, you revise it once, again margin is showing either in situ or invasive carcinoma up to the margin. Excise again that is showing. I think that then call it a day and convert it into a mastectomy.
One of the major reasons why the Western world is so finicky about the margin is because they deal with larger number of DCIS, and most of the patients are screen detected ones. So it makes sense that they would do a frozen, they would take the patient and do a specimen radiology, they would check multiple times. But we deal majorly with palpable lumps, and therefore our margin positivity incidence is far less compared to the West. So therefore, I don't think it doesn't make any sense to use an ultrasound guided excision, because that may be helpful for an impalpable lesion which is being dealt in the West. But for us, it's a palpable lesion, and so once you palpate and you can take it out, why not?
Fantastic. I think that is a great point. Our tumors are all palpable. Palpation for margin works best. Western, very impalpable tumors, very 5 millimeter small tumors, ultrasound guided excisions works as well. Better.
Yes. Another patient attitudes I've seen in the Western versus Indian patients, 20 to 30% reported positivity rates, re-excision rates is not acceptable in India. So not many patients will be willing for going for second surgery or third surgery in Indian situation. That's why when we started our program, now we have crossed around more than 1,000 BCS. We always try to keep the margin positivity rate around 1 to 2%, less than 1 to 2. So that should be our aim. Don't go by the Western figure. They are doing worse than Indian settings. 20 to 30% margin positivity and re-excision rates is currently not acceptable for an early stage screen detected breast tumors. You are going for 3 surgeries. That means 2 surgeries, which is not acceptable. So now with the change in the definition of margins, the re-excision is going down because they have changed the definition of margin itself. So that the re-excision rates are now just 1 to 3%. Yes, one is here, right time.
I welcome my dear friend, Dr. Vani Parmar. She is a professor of breast surgery at Tata Memorial and one of the finest breast surgeons in the country today.
Thank you so much for so many compliments. I just walked in, but I guess that one topic is such a hot topic everywhere that I thought I could still comment without knowing what the background was. So essentially, it's screening which created the positive margins. The more you screen, the more you pick up DCIs, the more there is an extensive lesions in the breast, and you will get any excision, you'll get positive margins. And that's why in the West, the margin positivity rate has always been super high. And of course, there is always a commercial twist to everything. And that's how you start doing MRIs, and that's how everything else is built on that platform. And the second thing, of course, is that if you have defined, redefined margin positivity, you will start getting your reports as negative. And that's how there has been a twist in the story.
Thank you, Madam.
Dr. Vani brings her own unique flavor to any debate, and we have had interactions with her at various forums, but very unique, based on her experience at Tata Memorial for so long, and really adds a lot of value to meetings, and we look forward to having a very positive interaction with her throughout the day.